Thank you, Dr. Vinita, for giving me this opportunity. So, I shall be talking about the IOL calculation and the penetrating keratoplasty scenario or the corneal transplant scenario. So, this is a 63-year-old gentleman who came to us for the visual rehabilitation. He had keratouveitis earlier in the eye, which has led to scarring as well as endothelial decompensation. So, we had to basically do a corneal transplant, plus there was a cataract. So, we decided that we will do a triple procedure. So conventionally, we generally take 44 as the standard K, or we take the keratometry of the other eye. In this particular case, we took a standard K of 44 for this patient. Axial length was 23.65 in optical biometry, and then we implanted a IOL of 21.5. So it was a uneventful surgery, did well after the surgery. Immediately post-op, 20 by 125 was the vision. However, after 6 months, the vision dropped to 20 by 320. So what happened? So now the spherical, his refractive error was -10 spherical and -12 cylinder. So why this happened? You can take a look at the topography. So the K reading, which we assumed would be 44 after the surgery, had become about 48 K1 and 55 K2, and the average was 51.8 K, and the maximum K was 59. So this was much beyond what we had taken a conventional standard K of 44. So that led us to think that maybe this is a time to change the conventional way of doing a corneal transplant, and a triple procedure is not giving us a optimal refractive outcome. So now that the cataract surgery has become more of a refractive surgery, these kind of outcomes will not be acceptable to the patients and will not give a very good vision to the patient. So now that we have a very good safe technology of phacoemulsification, we have viscoelastics which are very good, which can protect the endothelium. Probably we have to look beyond the triple procedure. So triple procedure was started way back in 1976 by Taylor, and this is about 50 years ago, and this was the time when aphakia was the norm. Okay, the patients would use very thick glasses after the surgery and they were fine with it. But the times have changed. And also there is a risk in the triple procedure. Those of us here who do corneal transplant would know that triple procedure, doing it in a cataract surgery in an open sky, is not a very easy surgery. There are risks involved, and if there is a upthrust, there is a problem in doing the ECC and putting a IOL. So, and as I said, there is variable refractive outcomes in triple procedure. So in this particular study, they saw that the refractive outcome could be as varied as -14.7 d spherical to +8 spherical. Okay, so there is a difficulty in calculating IOL power in triple procedure. And what K value should you use in triple procedure? That's also a challenge. Conventionally, as I said, we use 44K, but some people also use the K of the fellow eye when it is available. There is one study by Salahuddin, he has used a donor K of the the keratometry value of the donor eyes. So while the eyes were being enucleated from a disease, they took a keratometry on the donor eye, and that is the standard K which they use for their IOL power calculation. But that's not the norm that we generally do. But I believe that now the time has come to shift to sequential procedure, which would give us a much better refractive outcome. So this particular study, they studied 22 patients where they had keratoplasty done, PK done, and along with that the ECC was also done, but patient was left aphakic, and IOL was implanted later on once the K reading had stabilized. It takes about 6 months and beyond for the keratometry to stabilize in patients of keratoplasty. So you should, if the time permits, you should do a keratometry after 6 months, and based on that you should do the axial the biometry calculations and put the IOL, which gives you a much better. So in this study they got 95% of the patients were within ±2 diopters when they did a sequential surgery. And also in this particular study they did keratoplasty followed later by cataract surgery. So that also gives you a very good IOL power calculations because you have a stable keratometry in these particular cases. So when should you consider triple procedure? I would consider triple procedure only when the cataract is very advanced and if I do a PK now and a cataract surgery later on in a very hard, let's say grade 4, grade 5 nuclear cataract, then it will lead to a significant corneal damage, endothelial damage. So that is when I would probably do a triple procedure. And there too, now I have started doing a PK and a cataract extraction and leaving the patient aphakic and putting in a IOL later on. Okay, so I would do a PK first and then later on do the cataract surgery if the cataract is soft. If the cataract very hard, then I will leave the patient aphakic and implant the IOL later on. That's what I have started doing now. So in this particular patient, he had a adherent glaucoma and a PK ECC plus IOL was done, triple procedure was done, and as you can see, the refractive outcome was -3 sphere and -6 cylinder. Compare this scenario to this particular patient where I did a PK first because it was a soft cataract. Later on, about 6 to 7 months later, when the keratometry readings had stabilized, then I did the cataract surgery based on the stabilized K, and here you can see the refractive outcome is plus 1.25 sphere and minus 0.75 cylinder, approximately plus 0.5 is the spherical equivalent. So much better outcome, refractive outcome as compared to a triple procedure. If you are doing DSEC, then the situation is actually a little reverse because in this situation either you will do a combined surgery, or in my scenario I would prefer to do a cataract surgery first and then do a DSEC. Here the calculation is very simple. You do the cataract surgery, you aim for a minus 1.5 refractive error, and because your DSEC will cause about hyperopia of about plus 1.5. So you keep that into account. So your target is about minus 1.5 when you're doing the cataract surgery in a patient who has Fuchs, where you would do either a combined surgery or you will do a cataract surgery later followed by DSEC. So this is the simple calculation for DSEC. In DMAC again the calculation is a little similar, but here the hyperopic shift is just about 0.5 plus 0.5, so you take a target of about minus 0.5. So DSEC and DMAC is lot more simpler than a PK. Thank you for your patience.